Now we're going to talk about looking at the bones. Um, and I think what's important to do here is to kind of have the appropriate setup. Depending on the protocol that your institution uses, you may have something like a bone kernel or a bone reformat. If you have an axial like that, I think it's very helpful to have that set up here. Um, or if you have thin slices, the thinnest we have on this study is 1.25, but that's what we're going to use here on the left. I think it's very helpful for when you're looking at the bones because it can help you appreciate those subtle fractures. So that's kind of how I think we should set up our axials, either the thinnest slices that we have or specific bone kernels or reformats. And then once you're here, what you can do is put it on the bone window. I like to have the sagittal up at first, put it on the bone window there too. Then we go to the top. And what I like to do is actually start from the spine, and because the spine has a lot of things going on, I start by looking at the vertebral bodies and the pedicles. And basically what we can do is just scroll down, looking at these here, and just we're making sure to look for, are there any fractures? Are there any lesions in the vertebral body? Are there any fractures in the vertebral body? And we just go nice and slow and look through them. And then we get down to the sacrum here. And this is why it's so useful to have it on the other side so we can see what level we're at. And we can look through the sacrum all the way down to the tail. And we can go back up. And here we're looking for, fractures, anything unusual. We see some sclerotic lesions here. Those don't seem to be acute or anything too noteworthy, but we're finding them. And now we can get a good look at our hip arthroplasty on the right side. We can look down the femur here, look for any evidence of hardware complication. And then as we come back up, we can look at the pelvis. And we just kind of can go back and forth as needed to look at the pubic rami here, both the superior and inferior ones. And then we can make our way over to the other side as we come back up here. And now we can go down the left side, look at the pelvis, the iliac wing, look at the acetabulum here, look at the left femoral head, the left femur. We can go all the way down just to make sure we don't miss anything. And then we can go back up, looking at the pubic rami here, superior right here, inferior down there, right here, and now we can start making our way back up now that we've looked at everything down below. So now that we get back to the sacrum and back to the thoracic spine, now as I go back up the body, what I look at is the spinous process here. Just make sure we put it into view, our spinous process right here, and then also the transverse processes on either side. So now we can kind of look a little bit more on the posterior aspect of the spine and just make sure we're not missing any fractures or anything that's unusual there. And then we can kind of make our way all the way back up. And at this point, we catch a little bit of the scapulas on both sides. So we just can kind of scroll through them very quickly, making sure we don't miss anything. Just looking at now on the left side. And now we're in a position to look at the ribs. We only catch a little bit of the ribs, but what you can do is, if you want, you can trace each rib that you see to the anterior end, kind of going from posterior to anterior, or you can kind of split this up into quadrants and just look in specific areas looking for rib fractures. So what we're going to do is just take a look at the ribs on the right side as they kind of connect in the anterior surface, and we'll go all the way down, and we'll just scroll back and forth, either looking at each rib individually or looking in specific quadrants to see if there's any pathology that pops out at us. But it doesn't look like there's any fractures or lesions on the right side. Now we can look on the left. We'll just go back up to the top, and we'll look at these ribs over here, and we'll just go all the way down, catching all the ribs that we see, and go back up, just to make sure we don't miss anything. And you can alternate, which rib you look at as you go up and down, or which quadrant. But at this point, we've pretty much looked at everything except the sternum, which we can catch a little bit of here on the axial view, and we can just look back and forth and just see, because sometimes there will be little sternal fractures or big ones or lesions there. Pretty much at this point, we've maximized the utility of our axial view. Now we can come over to the sagittal. And I think what's really helpful with the sagittal view is just taking a look at the alignment of the spine, so we can see if there are any big fractures, any big misalignment. We could look at kind of like the facet joints here as well too, see if there's anything that's giving us evidence of an acute fracture. Another thing that we can do here as well too is look at obviously the vertebral body heights, the disc spaces. For example, there's some disc space narrowing that we can really clearly appreciate on the sagittal view. What you can also do is kind of take a look at the sternum here. Sternal fractures might be a little bit easier to see on this view. And of course, you can also look at the pelvis, the sacrum, the femoral heads, and the proximal femurs bilaterally too, down low. And at this point, what we're going to do is just kind of go to our coronal view. This is also on our bone window. And at this point, I think it's helpful to look on this view as well too, because you can get a good look at the alignment of the spine in this direction. Again, you can see vertebral body heights and disc space heights as well too. And then also looking at the pelvis can be a little bit easier on this orientation. Looking at the femurs, our hip prosthesis here, I think we can appreciate really well on this view. And then we can look at the pubic rami as well too. So ultimately, I think this is it'll get faster as you do it more frequently and as you know what to look for. But this is a pretty seamless way to maximize looking at the bones in all of the views, so you can grab and pick up on any pathology. And depending on your circumstance, I think another thing that you can do is actually go to a soft tissue window or an abdomen window, and you can kind of decide how you want to window this. Maybe you kind of tweak it, but depending on the circumstance, you may also want to actually look at the spinal canal here and look at the cord, and just kind of scroll through and make sure that there's no retropulsion of bony fragments or anything that's actually going into the spinal cord. And depending on how you window, you may also actually be able to see herniating discs that are coming into the spinal cord. That can be a little tricky depending on how you window it. You may have to play around, but in certain cases, you can actually see herniating discs or other soft tissues that are actually going into the spinal cord, and that can be very, very useful. So I think probably at the end, it doesn't hurt to just look with the soft tissues and just run the spinal canal and make sure there's nothing in there. But overall, that is how we look at the bones, maximizing all of our orientations.